coming. I thank you for the interest. We are all certainly being bombarded. You probably know more things about some categories than I do even today because we just can't keep up. So I titled my first slide to say coronavirus and overview, everything we know today. Because within an hour, everything I told you could change. So please be empathetic, if you will, for what we're trying to deal with all the changes and the updates coming from the powers above. And a lot of my slides, I'll preface this by saying some of them are outdated, so I'm going to free speak off of those for what's happening right now today. So bear with me. Okay, what are coronaviruses? We know they're respiratory viruses that have those crown-like spikes. Those spikes are what are telling that virus where to attack and make the person sick. So for example, coronaviruses are in the common cold. They cause common cold, but they can also cause more serious illnesses of SARS and MERS. And with SARS and MERS, and even with this COVID-19 is what we're referring to it can attack the deep lower lungs, and it makes people more seriously sick in some pockets of the population. We're still learning every day, and then really what I'm going to show you is a video that just gives a broad, very brief introduction about coronavirus 19, and you probably already know it, but it was just a good video, I thought, that kept things kind of clear on what we know.
Backstream. How does this virus work? How does it transmit? Where does it want to go? And let's protect ourselves. I'm Dr. Peter Lind. I'm a family physician in Toronto, Canada. The coronavirus is a family of viruses that can cause as mild things as just a common cold, all the way up to SARS or MERS. These are these bad pneumonias that we're talking about. And basically what these viruses are, they look like a tennis ball with all these spikes sticking out of it. And depending on the type of spike, it allows that virus to attach to certain places. So some viruses, they have the spike that attaches to your nose. So basically you just get a common cold. But the SARS virus and this new virus that we're talking about has the spike that allows it to attach to the cells in your lung. And when it attaches there, it puts in information to make photocopies of itself. So it uses our equipment to make more viruses.
I'm declaring a public health emergency of international concern over the global outbreak of novel coronavirus.
Most of the coronaviruses live in animals. In this particular case, it was from Wuhan. There was a fish market where they were selling live animals. And the thought is that the virus was in a live animal, then it crossed into a human. But then what we found was that people were getting sick in terms of healthcare workers, in terms of family members that were looking after them, which now meant that the virus can pass from human to another human. Just like all viruses, it needs to reach a target, which is your lung. And it has to get there with your health. It has no feet and no wings. So therefore it needs us to move it there. So that's why we keep saying, don't hang around sneezy people because you're going to breathe it in. And don't touch your face because that's how the virus is going to get in. The masks are helpful, but they're not necessary because they're leaky. The ones that you and I buy basically have pockets here, so therefore the virus can get in. What the masks really do is they stop us from touching our face. If you're sick, we tend to mask you, so therefore you're not spewing out the viruses to other people sitting around you. The true people that have the real masks are the N95. Those are sealed. These are for the doctors that may be caring for the patients. So in the beginning, the coronavirus would cause kind of like flu-like symptoms or a cold. So people just get the stuffy nose, that kind of thing. But you'll understand that as soon as that virus starts manufacturing in your lung cells, they're producing all these copies of the virus, all of a sudden now you kill the lung cells. So now you can't exchange oxygen. And that's why one of the early symptoms is people get very short of breath and they tend to have a difficult time breathing, and that's why they end up in hospital. So currently, unfortunately, we don't have a direct treatment for the coronavirus, so we don't have a medication that can kill it off. And so it's really supportive. So in other words, the patient can't breathe, we give them oxygen, help them to breathe. They can't drink, so therefore we give them fluids to support them. Their kidneys begin to shut down, we help them with all those things. So it's a very supportive process. This is a new virus that we've never seen before. So our immune system, our army, are having a hard time figuring out what to do. So usually what we have to do is we make something called antibodies. So these are things that can grab onto the spikes that we see on the virus, and it'll get rid of the virus for you. And that will actually bring you back to good health. So therefore the elderly may have a worse outcome. And of course the young children. So the babies, their immune system is not so good either, so they may not make those antibodies as well. So just remember your hands may be with virus. Virus cannot hurt you because it can't get through the skin. But the moment I do this, now I've brought the virus right to where it wants to go. So let's remember not to touch our hands to our face. So let's say you think that you might have been on a plane or you might have bumped into somebody that has it. What should you do? So the first thing is to contact a healthcare worker to tell them that potentially you have it. If you're feeling symptoms and you're going to go into a facility, call ahead. Okay, so whether you're calling the paramedics or whether you're calling the hospital or your doctor, just mention that you were on a flight. If you don't have any symptoms, then what we do is a little bit of a self-quarantine. In other words, we can just keep you away from other people, and so you don't go into parties, don't go with your friends, don't go into public transportation. So we can contain it very easily by making sure that you do a self-confinement, so to speak, for the, let's say, 7 to 14 days is the longest incubation time. So after that, if you're feeling well, then you don't have anything to worry about. So we get the facts right, and we don't have to be overly worried, but we do the right things so that we don't get the virus ourselves and that we don't pass it on to others. And if we look after each other in this way, this virus will have nowhere to go. It needs us to move it, it needs us to make copies for it, and if we don't help it, then the virus will stop. So we have the power to do that right now.
Yep. And your PowerPoint's at the bottom. And then hit F5.
Could you hear that audio okay? It's got kind of a soft, I'm sorry. Okay. I'm sorry if you couldn't hear it. Hopefully we've got it recorded if you want to. We're going to post today's session because with all the lieu of things coming out, we have canceled all meetings here at the hospital. And that includes this presentation, so this is the last one, and then we're recording it today so that it can be shared from staff who are going to come to the other session. Okay, like I said, this slide is, some of it's already outdated, so I'm going to just speak from the hips here. As of this morning, we have 37 cases. Those mean those are confirmed. There are lots of people that are being tested, and as they said on the media, this number is going to change, and it's a fluid number, that's for sure. To clarify on test kits, and especially this, anything I say, I would like you to communicate to your friends and family, and people who are anxious as well. Anything that's shared here today is probably important enough to share with your family members. When they say, does Wilson have testing? What Wilson has is we have the supplies to do the test, then the test has to be sent out, okay? So originally only the Ohio Department of Health was testing, and it did require at that time that we couldn't do a test unless we called the Ohio Department of Health first and got approval. Then the commercial labs came on the scene, and now it allows medical provider discretion to test. The other thing that's been confusing, testing is probably one of the top areas where it's been confusing, because when the commercial labs came to the front and we had other testing options, then it kind of opened up the panacea that we could test everybody. And so we were told in healthcare for guidelines that we should only be testing priority groups, meaning the elderly, those over 50 that showed signs and symptoms, those that are immunocompromised. But now when you have a president on the TV saying we're going to do big enough test kits to test everybody who wants one, as you can imagine, it's caused a lot of phone calls and a lot of confusion. Because right now today at Wilson, we have enough supplies to do 84 tests. That means to collect the specimens. If we got more kits, we could do more, but we're limited right now. So we are working hard in Incident Command. We've been working 24/7 to try to stay on top of what's being recommended and trying to get information out to you. But sometimes it changes so fast there is some time lag, and we apologize for that. Medical providers are encouraged to do 2 tests to rule out because there's still flu going on. People certainly are still getting colds. So that confuses how to sort out these patients as well. So the medical providers are encouraged to do what's called a rapid viral respiratory panel first. And then also, along with that, to do a rapid flu test. So within that viral respiratory panel, there is a coronavirus test, but it isn't the COVID-19. But we still want to do the rule out. If the coronavirus was positive in that panel, then the doctor at that time can add on the COVID-19 test to that. Okay. Again, most importantly, public health recommends patients call first. We are trying to get that language out to people on multiple levels. We have adapted the call-in line to Wilson Hospital. You know, one of the choices is going to be if you're calling this hospital to ask questions about COVID, dial 10. So that's to take care of some calls that are flooding into the ED type of thing. That's being created. I know there's some incident command. People here in my audience to speak up as I talk if you think there's some other things we could share at this time. Doctors' offices, when they get the phone call, people are saying, I have a cough, you know, I don't feel good, I've been sick for the last 5 days. They're to screen those and decide if they can physically bring them into their offices. We do want people to stay home if it's a mild illness. It's like they've been saying on TV, we really need people to stay home and deal with this illness because 80% of the people are going to get better. We need to save our resources and energy and staffing for those that are not going to handle the disease well. Travel history, there was a lot of focus on travel history at this point, and it's in every country around the world, and the numbers keep climbing. That's become more of a moot point. You know, you keep hearing on TV they're talking about community spread. You know, before we were trying to identify those people that came from specific countries, but now it's spreading. And so there's going to be people who get sick with this with no link of travel. So we can't sort people out and turn them away because they haven't had travel history now because we've got this community spread. The Ohio Department of Health has developed a hotline. We are using that and referencing the public to using that as well to avoid some calls that come into our place. Symptoms, I think you've heard this probably a lot. When we talk about fever, we're talking about 100.4 or greater. Cough, shortness of breath. Who are the most vulnerable? The elderly, and I've seen many resources that say 50. And we have come up as a region with Gadaha to have visitor restrictions that are being posted and signage is going around the hospital. They have backed that down to 50-year-olds for elderly. Severely immunocompromised and those with chronic medical conditions and those living in long-term care facilities. And if you have questions, if you hold until the end, we'll address those. So how are we managing the patient? Way back in early February, there was developed a triage tool that was given to the ambulatory centers of our hospital system and to the ED. That is now being updated. We're trying to give you better and more detailed guidelines that should come out today or tomorrow very shortly. Again, it was stressing on our triage form to call and interview and talk to these people and keep them home as much as you could. And then we had to address, and we have to address, what are we going to do when the worried well show up at our hospital. So many of you have seen, we have inflated a decon tent outside of ED. I don't know if you've seen that. So patients that call ahead or patients that present to triage, they sound like they could fall in the suspect category, are being directed to come through the tent. They'll be assessed, brought in through decon, because that's their negative pressure room down there. And if we had to further work them up, then we'll escort them to one of the exam rooms that's going to have a Feltra air scrubber unit in it. We are also in Incident Command talking about, with our county partners today, do we need an alternative testing site to send people from the community? Don't come to ED to be tested, don't go to your doctor. If you're just looking for a test, go to this alternative site. So again, more will be coming out about that. Priorities for testing. This was what we were living with. The hospitalized patient, for sure, we need to have test kits and prioritize those kits for those people. Other symptomatic individuals, we need testing for them, and they are including healthcare workers. Now, I want to clarify that. If you think or you get exposed to a COVID-19 patient, you will be interviewed so that we can determine your level of exposure. Because if you work with a patient who has respiratory protection on and you put on your personal protective equipment right away and the person tests positive, you have not been exposed. So we're going to assist you in understanding what does an exposure look like and what does it mean. If you were a HUC or a registration person, you stopped in the room real briefly, they're working with a COVID positive patient, and you simply stuck your head in, asked a question, and went back out, and then you later learn, oh, that person tested positive for COVID-19. That is not an exposure, okay? If you have a true exposure, we've determined you have true exposure, yes, you could probably, and you will probably be quarantined for 14 days at home, self-monitoring your symptoms. How do I protect myself? I read a really good reference that said, you know, we're worried about this PPE and our supplies, and there's a justification for that. But what we forget is our greatest tools are using our hand hygiene and our respiratory hygiene and educating our family and friends to get on top of this. The other thing is for people not to come to work sick, for people to stay home when they're sick, and have a high level of personal responsibility. And I can't stress that enough. They say that worrying about this PPE, that's our last level of protection. You know, our first level is trying to keep people who are sick home that can handle it, and trying to do these measures of protection. I do at this time really highly encourage everybody to develop that habit of coughing and sneezing into your sleeve. If you work alongside somebody who's doing this instead of this, please be brave enough for the good of the world here to re-instruct them and to encourage them to use their arm. Frequently touched surfaces, we need to be disinfecting them frequently during our shifts. So while we're here, I'm holding this up because it's a remote, I'm talking about cell phones. Those types of things. Our hospital disinfectant products that we have, our Sandy wipes, our green tops, everything's fine for cleaning coronavirus, okay? So we don't need a special product. We're not needing to bleach clean these rooms like we do with some other diseases. Our current products are fine. You will not be given harassment if you stay home because you're sick. I don't want you to all leave. We need you, but stay home if you're sick. Okay, protection in the workplace. What has happened, again, since we've had these slides, we were pushing the droplet mask on the patient as soon as you think you might have somebody coming through the door. I'm going to finish the slide and go back. And then we were putting staff in the highest level of protection, the airborne protection, gowns, gloves, goggles, all this kind of stuff. While the virus is believed to be spread by droplet, the reason why they went to that high level of PPE for recommendations at first is because it was still a novel virus. And then I'm going to talk about QC checks if you use those higher levels of respiratory protection. But what has happened is when they say our supplies are critical on TV, they are not kidding. And we are not exempt here at Wilson. We have a serious issue about supplies. So we are working on this very actively today to come out with recommendations of what we're going to do for supplies. So I'm going to give you an example. While we push the mask for the patients, we may not have enough droplet masks for our staff. So do we keep using the droplet masks and giving them out to patients? Or do we save them for our staff? And do we have patients just use Kleenex to protect their mouths? We are looking at those issues. Right now, what we're leaning towards, and if there's anybody here from CCU, but for our hospital, because the droplet masks are so critical, we may stay at that higher level of protection with the full respiratory equipment because our supply is better for that, for the patients that are being admitted. Those of you that work in outpatient departments or outpatient facilities, it may be different for you because we may have to save, again, our supplies for the more highly critical patients. Okay, I want to review, if you are somebody who's going to be putting on an N95 or a PAPR, and you're working in an airborne isolation room, we want you to use PAPRs, number one, because a PAPR automatically takes care of protecting your eyes, your mouth, your nose, and it's purifying and scrubbing the air that's going over you, and it's the highest level of protection. Okay? You should not be putting on an N95 in any circumstance if you haven't been fit tested, as long as we have plenty of supplies here. The fit test for the N95 is done annually for those departments and employees who normally have an option of wearing an N95. Okay? If you're putting on an N95 respirator, the QC check for that is you put it on, make sure it's sealed against your face with the nose piece. There's a little piece of aluminum in there to get it tight against your nose, underneath your chin, and then you take in a deep breath, a sudden, quick, deep breath, and that mask should start collapsing towards your face. So as long as it moves in, that means you've got a good seal. For the PAPR unit, it's a motorized box connected to hosing that goes to a hood. And the motorized box is what we have to make make sure we're keeping charge. And so each time when you put that PAPR system on, there's a little black cone in with the PAPR unit. It's got markings on it. You put it on the hose, turn the motor on, and it's to free flow up to the level of those marks to make sure that you've got a fully operating motor. Okay? We do have PAPRs in sterile processing, but I will tell you right now, because of supply issues, we are so tightly controlling that you need to make sure that your department's not running somebody down to take one out of that area. You have to go through proper channels like the nursing supervisor, or if anything that you're asking for from the floors has to go through materials, because we are counting every single unit and every single piece of supply that's being used for these patients. To let you know, other than I've mentioned Incident Command, we're having various conversations with small groups, obviously internally, but we have formed Incident Command. You heard Code Yellow called today. We had been meeting in Incident Command last week, but we've upped it to Code Yellow because we need critical current data all the time from your areas of where you work. We're going to be working hard to get out information to you guys on a daily basis, what we're doing in Incident Command, so you know we're trying to move forward. All of us that are intimately involved are getting bombarded by daily phone calls or emails from local health departments, state agencies, and national organizations. I've already talked about the Incident Command. We formed the Incident Command this week is working 8 to 5 p.m. downstairs here. So we have expanded, putting more time in that. And then again, updates will be sent out to staff. I can't stress enough, if you're an employee who doesn't normally check their email, that when those weekly, what do they call it, Wilson Weeklies come out, you usually don't take time to read them. This is the time to be reading things, okay? You need to schedule some time to be staying informed, or we're going to also ask managers to step up and make sure that they're reminding staff to be looking for these communications as well. We are working with external partners. Some of you may be aware that's been posted within the last 24 hours. We're working with the Greater Dayton Area Hospital Association, which means our regional hospitals, to try to do some things as far as uniform action and similarities between facilities. So when we move today to the visitor restrictions, our visitors restrictions are the exact same they're going to find down at UPMC. So we're not going to have patients and families complaining, well, Wilson's letting us do this, but I went down to pick one, they didn't make me do that. We're trying to eliminate those kind of PR nightmares, PR, public relations nightmares. I'm a little tired. Okay, so, and I will tell you too, like I went to a meeting of the extended care facilities. They organized the whole county of those groups of people to come together. Fire and police were there, our hospital was represented, the health department was represented, and we went round table and we talked about what we're doing. I felt really good and reassured how active the nursing homes have been on trying to protect that population, but also to protect visitors. So I was impressed, you guys. It was pretty impressive. We had talked about hosting a community forum where the public can come and ask questions and answers. Well, as you know, over the weekend, nobody's supposed to go anywhere, so we are not going to have a community forum. And you have heard, or you will hear, we're really doing things to step up. Like I told you, this is the last session of this. We're not going to be having educational classes. There'll be various other things that have gone out. All right, let's answer these questions first, and then we'll answer whatever other questions you have. How do you get sick with COVID-19? Anybody? Droplets. Okay, so it's going to be a respiratory transmission method. How do I know if I have it? This was a little tricky. What's that? That is really true. I mean, it's hard to sort out, as I said earlier, if it's the flu or if it's something else. So really, the only way you know you're going to have it is the test. Okay? But I can't stress enough, that test is not supposed to be a screening tool. We're going to get to the point where, yeah, we're all curious. I mean, now, when any of us catch a cold, we're going to think, do I have it? You know, but we can't race and get a test necessarily for it because there's just not going to be enough test kits. If I get it, will I die? Okay, probably not. You know, 80% of the people are handling it fine, just as a common cold almost. The people that are dying, I will tell you, typically had a connected travel history, did they have comorbidities, if they're not going to reveal that kind of information to the public, but those are more of the people who are dying. Are there any people who are dying that are healthy? There are some. I don't know the percentage, there are some. So that, could happen, but again, the majority of people are going to handle it fine. I will say, personally, because I'm well over 50, I am a little concerned that the highest percentage of death rate happens to be in the 50-year-olds. So, shouldn't we all be wearing masks in public? I think we've already talked about that. There are not masks for us to rank that recommendation. And the other thing too, when this was early rolling out, if you looked at the people, like I'll pick on China for example, that were all out in their masks. I watched one newscast and this guy had his mask here, but his nose was totally open. It just doesn't give people the protection that they think it does. If I work with a suspect case, am I going to be quarantined for 14 days?
Depends on if you have an exposure.
How many say yes? Okay, so the rest of you all say no? Okay, and that's because I had told you earlier we're going to assess your exposure. We'll help determine if you really do need to be quarantined. And then if I immediately use infection prevention measures, PPE specifically, and hand hygiene, am I sufficiently protected? I want everybody to go like this. Okay. And, whoops. I hit that.
I think that was the last of it.
Nope, I have one more.
You do? Hit the little play button again.
Down here.
Yep.
Okay, let's go over the answers that I typed up. It's passed with close contact, so you really do need to be less than 6 feet. And again, it's because it's basically droplet and it's a larger microbe size, and it should not travel like we worry about with measles or TB or be suspended in the air. The incubation period is 2 to 14 days. Diagnosis is only made by the testing kit. Dying is not likely, but we do know at this time anyway that for every 100 cases, 2 to 4 people will die. We already talked about masks. We have been working closely with the health department when we're isolating or sending people back home to self-quarantine. Over the weekend, it changed public health. It was supposed to be notified even if we were testing somebody, and they were going to stay in touch with that family to see how they were doing. Now it's changed to where public health will be it'll keep them busy enough, but public health only needs to know if the test is positive, and they will be following those people. So that's the scenario with that. And we've already talked about you'll be safe if you put your stuff on. Is there any good news? I hope so. There's continuous update and change that we need to attend to, but we've had history of working through other mass diseases. We've worked through the pandemic, we worked through SARS, we've had to deal with Ebola. We have drills where we've had to address in the past what do we do if we don't have enough supplies, what do we do with surge capacity of patients. So hopefully those things help bring experience to our actions that we're trying to take to deal with this particular disease. And I will tell you, sitting in the Incident Command Center, working with all the leaders and people that are in there, it's very impressive how we pull together here. We are good people wanting to do the right thing. I will ask you to please be patient with us. Don't be frustrated if we send out guidelines today and then we tell you to look at the new guidelines tomorrow. We're not trying to have you think we don't know what we're doing. It's just that things honestly are changing that fast. Okay. Questions? There's my extension. I'm not at my desk very much, so you'd have to have me pager. I've been pretty free about my cell phone if you need it, and we'll try to answer questions and issues that we can. But questions from the audience?
What can we do to get more copies so they're more readily available?
Okay. Okay. First of all, we need those guidelines to come out today on what kind of personal protective equipment is going to be used in what kind of scenario. I hate to step and say anything about that right now, but what we may do, I'll go this far, is to say that the PAPRs, the N95s will be for those patients in those isolation rooms. When they go for ancillary services, they will be put in a mask, and you would only need to work with them in a mask, because we're so short. We are probably going to preserve the PAPRs for patients that are in an isolation room, the inpatient patients, okay? If you go upstairs to do a portable, then you'll be putting on the N95 or the PAPRs up there. If they're down in ED and you're going down to provide services. When you go in those particular rooms, you're aware of the PAPR and they've got them housed down there, okay?
Now, what if we have to take him to radiology for a test?
We're working on that because it may be that we use our scarce amount of masks, droplet masks, and send them in a droplet mask for you to perform your service, and then they just go back and you don't do anything. You don't use anything. We may have to do that. It's not normal operations, you guys, that's for sure.
And these peppers, they take them off and clean down from the inside. And that's supposed to be,
We were using our disinfectant wipes inside the PAPR hood. You fluff it out to air dry. If you immediately need to get back in it, there should be one extra PAPR, a dry one that you can put on while the other one's, drying. And we do have hoods in supply. I can't quote you numbers, and it probably wouldn't mean anything anyway. But we do, and we've done this in normal operations when we have airborne, we reuse the hoods. But like say, Judy and I are working together as a nurse up on the floor. She uses heavy foundation, and the hood kind of looks, whoa, to me. We can get a new hood for now. Okay?
Linda, do they have to be working outside also? Because these are
The whole thing. The whole thing. Is that what you're asking? Of the hood, the PAPR hood? Yeah. It needs to be disinfected thoroughly. And always finish with hand hygiene. We have to remember to always finish with hand hygiene.
so if the patient comes down, say for CT or something, what are we safely down after? Is there a certain amount of time we have to wait after?
Okay, well, two things of that I'm glad you brought up. We are asking staff, if you're providing ancillary services like you're describing both from radiology, we're asking you to clean yourself the most frequent and the contact surfaces that patient had interaction with our normal disinfectant wipes, okay? You should verify on the side of the bottle the disinfectant wipe. It gives you how many minutes it needs for a kill time. Usually it's 1 to 3. Okay, so as long as you thoroughly have wetted and you used enough of those disinfectant wipes to do a good thorough job, and you let it set that 1 to 3 minute range, you're ready for the next patient. Okay? And that has been asked about, what do I use to be cleaning? And same thing, anybody that's here from, if you're in a triage area or registration area, we're asking you to disinfect anything that the patient's interacted with and handle, okay? We're not sending housekeeping, like let's say you did an x-ray and the patient was there. We are not asking housekeeping to come down and terminally clean that. We don't have the staff or the time, and we don't need to do that level. We will, when a patient gets discharged out of the airborne room, we'll be terminally cleaning those inpatient rooms, but we don't need to do that for casual time, that small amount of time.
From the inpatient perspective, when will we initiate isolation?
As soon as you hear the doctor saying, or the medical provider, this could be a COVID-19.
So
Is that what you
we're
mean?
doing that respiratory panel for patients, essentially they need to be in isolation.
I would have a discussion with the provider and ask them, if we're doing this viral panel, and if that coronavirus comes back positive in the panel, are you going to test for COVID? And probably because we have airborne rooms, I would rather see patients put in those while we're trying to have those conversations with the medical provider than to wait and hear about that later. Oh, he's going to throw in COVID-19.
So they need to be in the airborne rooms
And-
and those turned on.
Yes, and let me tell you, part of the group that we're working on today, we are probably going to designate a care unit. Okay, it's not going to be every bed upstairs could have a COVID-19 parasite in it, or all our negative pressure rooms are options. We're going to have a central area for them to go. And it's probably going to be second floor.
That will not be air, but those rooms will be able to have a,
There are 2 negative pressure rooms on telemetry unit, 220 and 219 are negative. They can be set for negative pressure. And as I understand, they're prepared to do that today. Okay. And then we'll use ICU 201, and we'll use 220, 219. And down in ED, I think I already said this, they're going to go through the 10 outside, which has a HEPA unit on it. And then they're going to go into decon in ED, which is a negative pressure room. And then they're going to be moved, if they need to, because of patient census, to an individual room in ED that'll have a freestanding HEPA unit in it.
And
Yes.
if we get really bad, then our hospital becomes like cold to many of those patients. And we
Every day, that the DAHA group that I'm talking about, the Greater Dayton Area Hospital Association, we are supplying to the central office of that group our daily census on beds and supplies. And they do that because they need to know, like, let's say UVMC is being slammed and Wilson's not being slammed. Then we can talk together as hospital systems and say, hey, can you take some of our patients? Or, hey, we need to give you some of our patients. So those are daily. I think they're even twice a day they're doing bed census now. On a normal day, they do it daily. So yeah, that could happen. And the other thing I'll tell you, as we make determinations on what services we're going to continue or services we need to discontinue, we really need to pull together as a team here. You may be asked to do some tasks that aren't in your normal job description. You may be asked to go and help in another department. You may be asked if we set up screening for employees as they come into work to go work that station to help the screen employees. We're going to have some needs. Bobby, I'm picking on you because you're the closest that I can see. You're from Incident Command. Is there anything else that you think, to at least, information will be coming out. The next couple of days, information is going to be coming out a lot out of Incident Command. I can give you an example of how fluid this is and why we're asking for patience from you guys. We're sitting in Incident Command. They've put up what's happening on a TV channel behind us, and we see a CDC. I don't even know what the job position of this title guy was, but they are considering doing a 2-week shutdown of everybody, everything, across the nation. Now you can bet it's not going to include hospitals, but is it going to impact us all as individuals and humans? Yeah, so, we're trying to address those issues too.
If we were to be exposed, how long can we have it and be contagious before we get symptoms?
If you're,
Are we contagious if we don't have symptoms?
they don't know that yet. So many diseases have what's called carrier state, where they don't get sick with it, but they're a carrier. This disease could have that characteristic. We're not sure. They think, because if you've heard Governor DeWine, he says, I think we probably had 100,000 cases. Is that the number he's throwing out? Something like that. We already have probably had 100,000 cases in Ohio. We just didn't test them, we don't know. So to that point, maybe those people were symptomatic, maybe they weren't in that group. Yes?
Do you know how those effects
It's very interesting because one of the sessions that I did, Dr. Pedler was in it, and also I've had a couple doctors in this group. The other one was our hospitalist, Dr. Patel, and there was a discussion about that. What we know today is it doesn't seem to affect the pregnant woman so much, which is very interesting because I will tell you, for every other disease, when a person's pregnant, you're normally immunocompromised, but they are not seeing that in the pregnant woman. There is discussion if the mother is sick when she delivers and has COVID-19, they will house the baby and mother together, and then public health might possibly have to deal with, okay, that mother's got to go home and be quarantined with her baby for 14 days. What's she supposed to do with the 2 and the 5-year-old at home? Do we move the mother and baby out to an alternative living arrangement? Those kinds of things are being looked at. So, yes.
When do they think the peak season is?
I don't tell you. I wish I knew. What I'm hearing right now is they think it's within the next 2 weeks for us. We're going to see our numbers climb, whether that means that's the peak or whether that just means the last 2 weeks we've really done a lot of tests. That's going to be confusing. So I don't know. Way back when this was just kind of starting, we had an infection prevention committee. I think it was the end of January, and the ID doctor was in there, and I think we asked him that question, Dr. Baraki, and he said, probably March. Well, we're in the middle of March, and now we're opening up testing kits, and I don't think we're going to call this the peak month, And the other thing, and I think they're doing a better job telling the public this, and I'll tell you this, the reason why they're doing these really dramatic measures is it's not going to prevent this COVID-19 from coming and people being sick. We're just trying to get it to be a number we can manage it. Keep the spread of the disease where we can better manage our staffing, our supplies, what we're doing with care. So we'll have to see. hope this helped. Thank you all. This is a lot of people here today. Please make sure you've signed in. Please let your other coworkers know we are canceling the next 2 sessions, which we're going to be tomorrow evening, but this is videotaped. So.
Where do you find the video at?
They're going, you want to speak to that?
We're going to send it to Mark.